Wound healing and scarring. Here again is Dr. Pei.
Okay. Hello again. So we're gonna switch gears a little bit here. So wound healing and scarring is our next module. I have no financial disclosures. We're going to talk about the normal wound healing process, and then of course talk about disturbances in the wound healing process. Talk a little bit about wound care and skin grafting. Most of this is very sort of surface things, so please forgive me if you're a wound specialist and you go, that is not what we do, and this is not in depth enough. Okay. All right, normal wound healing. And these are high yield topics for examinations. The first question I like to start with, please, is which of the following cell types is crucial for proper wound healing sequence? Wow, great. Macrophages, right? Macrophages are the cells of life. They destroy, but they destroy to lay a foundation. They destroy to clear debris to lay a foundation for us upon which we can rebuild, right? And so macrophages are incredibly important for this entire process, all right? None of the other cells are important, but they're not indispensable like macrophages are. Let's give you that global perspective on what happens. We cause injury. Everybody in this audience causes injury on probably a daily or at least a weekly basis by making a skin incision in somebody, right? And as soon as you cause that primary injury, our body sets in gear to try to heal that injury. Sure, it can't really do that while you have the abdomen fully retracted on its side, but as soon as you bring it back to midline, that process has already begun, and it's actually going through this global perspective. As soon as you cause that injury, whether it's a trauma patient or you cause the injury by making the incision, the body responds it to the same way. It calls upon its inflammatory warriors to rally them and bring them to the site of infection or the injury, and to try to clean up the debris, start enhancing the migration of other cells to that region, so that ultimately the goal is to do a matrix deposition, the matrix deposition on which other cells can come and grow, known as fibroblasts. Those cells come in and they say, all right, now the area is clean. They lay down this lattice work upon which I can grow, right? And then epithelialization happens. And as epithelialization happens, the underlying, what we're not seeing in all of this, is the scar maturation process, which can go on for months. And so this is what happens in a normal sequence of things when you're injured, right? Okay, so normal wound healing is classically taught as three phases, right? And the phases overlap considerably, right? In the beginning, you have an inflammatory phase, then you have a proliferative phase, and then you have a remodeling phase. You go back to this idea, this global perspective. It's the same concept. It's to say, here's an injury. I have to incite inflammation. And inflammation, all of us have grown to think of inflammation as a bad thing, right? But inflammation is our body's natural response to injury. It's our natural response to sepsis, shock, everything. And the reason that the inflammation happens is that it's a process by which we can recruit other very important cells to the area of injury so they can nip it in the bud. When these cells are recruited by the inflammatory process, then a very robust proliferative process happens. Lots of things are being secreted, lots of things are being built, a lot of debris is being cleared off, and then at the end of it all, when sort of the storm has calmed, the remodeling process happens, right? It's just saying, all right, I got all the basic elements that's necessary to be here for this wound to mature, but now I'm going to actually mature this wound over a sustained period of time. Let's start with the inflammatory process. It is our homeostatic response to stop bleeding. First and foremost, as a trauma surgeon, my first job is to stop bleeding. Our body is designed that way too. When you make an incision, right? So, right, and of course, we always say, when you make a skin incision, you know how probably a lot of you don't like to take, I love to take Bovie to the skin, but classically, you're not supposed to take Bovie to the skin all that much, right? You're supposed to make a sharp incision, and you go, don't worry about the bleeders on the skin. They all stop, right? They all do stop. And if they don't stop, you just hold a little pressure on it and it stops. And the reason it stops is not some magic. It's because of this homeostatic response to stop bleeding. It's a very complex process. It doesn't happen like that because it takes a few minutes for things to come into this lattice work to stop the bleeding, right? What's happening is that there's a vasoconstriction that happens immediately. We also think about this in all of our surgical procedures. We say, all right, well, I think that the bleeding that was happening before has stopped because it's vasospasm or vasoconstricted now. But let me just watch it for about 5 minutes, just in case when the blood pressure comes up and the vasospasm stops, maybe it's going to start bleeding again, right? We've all heard that, and we've all seen that happen. Okay, this transient vasoconstriction is mediated by thromboxane A2, which is something important just to kind of pack in the back of your mind. Thromboxane A2, macrophages, these are very important words, and prostaglandin. All right. Thromboxane A2 will cause and induce vasoconstriction, then causes a fibrin clot deposition to occur. After the fibrin clot deposition occur, it induces platelet activation, and platelets will release platelet derived growth factor, and then this entire complex then starts activating a production phase of causing other inflammatory cells and more platelets come in, right? So you get the PDGF and the TGF that are both chemotactic, which means that they attract cells to come to them. So it's kind of like the pancreas that has the enzymes that activate themselves, that activate more, and it just keeps on going like this, and it becomes exponential. This is the same process, right? More of these enzymes are produced, and the chemotactic process says, hey, everybody come over here, this is the site of injury. Shortly after this transient vasoconstriction, we can't be vasoconstricted forever because, well, the nutrients and the milieu that needs to be at the inflammatory site to help the healing process can't be delivered there, right? The conduit eventually has to vasodilate. So vasodilation happens. That's that erythema that we see, right? That's the redness that we start seeing. The vasodilation ensues the facilitation of transport of wound healing substrate. And it's at this time where we get the increased permeability and the endothelium. It's designed by nature. Let's let the endothelium be leaky so that the chemotactic substances have attracted all of the substrate for building, and I need that substrate to get to where it needs to go by making the endothelium a little bit leaky, right? Well, what's the side effect of that from we see clinically? That's the swelling we see from the leaky endothelium at the site of injury, right? Clinically, we see swelling, warmth, erythema, and pain. Pain, as you know, is also thromboxane mediated. The end of the initial healing cascade produces large amounts of debris, right? It's a mess. You can just imagine it. Kind of like that alveoli picture I showed you in a pulmonary contusion. So there's a lot of clot. There's bacteria. There probably is literally debris. If you scraped your arm on, I don't know, some ground or gravel. There's devitalized tissue. There's protein. There's foreign materials. And the PMNs, the polymorphonucleosides, the macrophages come in there and they clean it all up. They just sop all this stuff up and they peak within 24 hours. And they clean this process up. Right? The macrophages then arrive next, and they peak in 2 to 3 days. The polymorphonucleosides are not indispensable. They're very important, but the macrophages are absolutely indispensable for this process. Okay? Macrophages are not only they don't only work in a phagocytic mechanism. They also produce important growth factors that attract fibroblasts. And of course, fibroblasts are very, very important for the final product, right? Or the beginning of the final product. So now you got polymorphonucleosides are coming in, you got macrophages coming in, try to heal try to clean up the scene, and then after the scene is cleaned up, you get the fibroblasts and the endothelial proliferation. Things are growing at this point, right? Things are cleaned up, things are growing, and this amplification of this process, like I was saying, is exponential. It's very, very fast. And by day 7, the incision is strong enough for us to remove our sutures, right? Now, you all know that, and this is a different process by epithelialization, which we'll talk about in a little bit, and you all know that we tell our patients, go take a shower after 48 hours because largely the skin has closed by primary intention. That skin is closed. What you're not seeing is everything that's happening underneath it. It's still going through all of these processes, all right? Okay. Proliferative phase. So we got through the inflammatory phase. That was angry. It was chaotic. It was very involved, right? And so now all the players that were there for cleanup are on their way out, and all the players that are here to rebuild on the new foundation they're here during this proliferative phase, right? So during this proliferative phase, the goals are production of granulation tissue, that red, healthy, neovascularized tissue that we look for on patients, particularly in patients who are closing and by secondary intention. Fibroblasts proliferate, and the fibroblasts are proliferating due to a host of growth factors, some of which are produced by macrophages, some of which are produced by platelets. The endothelial growth factor encourages angiogenesis. You know, there's so much research out there right now about can we have man-made angiogenesis, right? Can we produce factors? There's a lot of interest in these growth factors. So we have innate endothelial growth factors that encourage such angiogenesis. And then at this point, the fibroblasts are depositing collagen, which of course is the structure of life, or structure of our anatomic life. All right. I pause for a question then. Hydroxylation of collagen amino acids is important for stable cross-linkage of collagen and paramount to the stability of the collagen deposition. This process is facilitated by all right, so 76, 2/3, no, that's 3/4 of you chose vitamin C. This is scurvy, isn't it? This is scurvy. This is the sailors that were on the waters for months and months without any oranges, I guess, no vitamin C. And they developed easy bruising, all the things that you associate with poor wound healing, right? And so vitamin C is incredibly important for the stabilization of the cross-linkage of the collagens, not the deposition of the collagens, but you know that the collagens themselves, if left to their own, if left to their own, they will just kind of lay down every which way, right? But it's not until they're cross-linked by a hydroxylation process that is vitamin C dependent, where they become strong. That gives us our soft tissues its tensile strength. And I just want to point out for this question that we should all be very comfortable with what vitamin, as it is referenced to wound healing and other areas that we're talking about, is vitamin A, B12, D, and E. And you just want to have in the back of your mind, where do these vitamins come up and why are they important in clinical scenarios? Okay, vitamin A we'll talk about a little bit later. Okay, collagen types. If you were lucky enough to have a simple question posed to you, which I don't think because it's mostly clinical scenarios, but if the simple question just came out, what is the predominant collagen type in our body? You would say collagen type 1, right? Okay, but if the question was a little bit more specific and said, what is the predominant collagen type in the proliferative phase of the wound healing process, that would not be type 1 collagen. In fact, it would be type 3, the immature collagen. All right, type 3 is the predominant during proliferative phase. Type 1 is so important, right? Because that's the strength of our abdominal wall. Our fascia comes from type 1 collagen. Okay, type 2 is cornea and cartilage. All right. So we talked about the inflammatory phase and the proliferative phase, and finally, when all this stuff has been laid down in this lattice work, we're at the very very important, but the later stage of things, and it's called the remodeling phase, right? The remodeling phase is to say that outwardly you're looking at the patient, they're in your office for a post-op check, and you say, you know what, you've healed really, really nicely. And this is the point where they say to you, hey, doc, when can I go back to doing sit-ups after my incisional hernia repair? So this process, though, takes up to 2 years, and it can happen up to 2 years. And of course, it also is dependent on a lot of other factors about wound healing, which we'll get to, right? The remodeling phase is known as a phase of collagen equilibrium, right? So the trick there is there's no total overall change. Amount of collagen doesn't change, but the type of the collagen changes. So it transitions from predominant type 3 to predominant type 1. And yet overall, you don't really notice much change. There's not a whole lot of increase in total volume of collagen. The fibroblasts at this point say, all right, so I've laid down the mature type 1 collagen now. I'm going to start receding. I'm going to leave the scene, all right? And you know that 70 to 80%, you should expect 70 to 80% of the original tensile strength in the best of circumstances, right? And none of our patients in 2016 seems to be in the best of circumstances, right? They all have, a lot of them have morbid obesity. Some are on steroids, some smoke, some have prealbumins of 2, and the list goes on and on and on, right? So in the best of circumstances, they get to 80% of their tensile strength. And I say that to my patients, you never get back to 100% tensile strength. And no, you can't do sit-ups to strengthen your fascia, right? 50% of your tensile strength is achieved by week 6, all right? So, you go into the literature, I don't know how many, I don't know what the audience's counseling of the patient is. Just within my partner group, like we have 10 partners in our faculty group, in our section, nobody seems to give the same instructions about post-op instructions. It's like, I don't get it. So I tell the patient, I go, you know what, I'm making all this up. It's so arbitrary, but I say 20 pounds for 2 weeks. And they go, okay. And somebody will say 10 pounds for 4 weeks, right? And I know this because sometimes you see your partner's post-ops and you're like, they said, but Dr. So-and-so said that I'm not to do 5 pounds for 6 weeks. And I go, so you basically can't do anything with 5 pounds, So none of it is really evidence-based. And the only thing that I could potentially say is scientifically based is that if you achieve your 50% of your tensile strength by week 6, maybe that's the reason why people want to wait 6 weeks. I don't think so. I think people are just randomly coming up with things, and wherever they trained, that's kind of just how they followed it, right? Okay. Let's take a look at our what's the word again? Asymptotic graph of life, right? Everything is in this shape in physiology, okay? So the y-axis is your tensile strength, and the x-axis is the chronology, or the number of days. And you know that you see how it plateaus. It plateaus, but it never gets to uninjured tissue, right? So it's just better never to have an incision, because you're never going to get back to 100%. Let's talk about epithelialization, okay? All right. Epithelialization is inverse proportional. Success is inverse proportional to bacterial load. This gave people a lot of push to say, well, if I have somebody who has a wound to heal, they should all be on antibiotics. And so then we poo-pooed that and said we shouldn't be putting everybody on antibiotics. You put everybody on antibiotics with the exception of the burn patients. Are there any burn surgeons in the audience? No burn. Okay. But burn patients it seems to be a different management plan, because for them particularly that a bacterial load to a certain power is associated with worse outcomes. So they do put antibiotics prophylactically for those patients, but the vast majority of patients do not need prophylactic antibiotics to help them heal. Well, we all know that. None of us keep our patients on ANSA for 6 weeks, right? It is also dependent on the extracellular matrix. That, of course, we already talked about that. You have to have substrate to be able to epithelialize. If you don't have collagen, you don't have vitamin C because they can't cross-link and stabilize. You don't have proteoglycans and fibronectin, and those are substances that kind of floated along with all the chemotactically attractive things when the endothelium was leaky, right? If you don't have those things, you don't have any substrate to heal. Then you have dependent on neovascularization. So who are our patients who are neovascularization impaired? Are smokers, of course, right? So there is a cellular basis for the reason why there are risk predictors of poor healing. We're reading these papers and we're like, wow, this is fantastic. How'd you guys come up with this stuff? And it's based on physiology, isn't it? Like the smoking and the substrate from a nutritional standpoint, they're not there, and you don't epithelialize well, okay? Scar formation. All right, scar formation is normal. Past a certain age, everybody will get a scar. Sometimes they get a little lighter. Sometimes they hyperpigment. But scar formation is just what it is. It's part of our normal, right? And the reason scar happens is because you have violation of the dermis. Scar is disorganized collagen. Okay, and you may say to yourself, and we're going to get to a point where we talk about different abnormal scar formation, but the normal parallel collagen layers are never completely formed. Right? And that's because there's no longer uninjured tissue, is it? Whether it's because so if you made an incision and you were super delicate and you were really delicate with your Adsons and you were closing with, just doing all the right things, and you didn't take a lick of electrocautery to the skin, you have a perfect setup for as small of a scar as possible, because in that situation, your collagen is going to be lined up as parallel as it possibly can, right? But even in that circumstance, it's not going to be completely parallel. That's why incisions parallel to tension lines form less pronounced scars. There's the basis for that, okay? Because if you're pulling against tension, those collagen have absolutely no motivation to stay in line with the skin line, the incision. Stretch marks is interesting because stretch marks is the destruction of the collagen and the dermis, but the epidermis is intact. That's why you get that little, the skin is the surface is very intact and it gets that discoloration to it. But what's happening is the underlying collagen has been destroyed and never to be repaired, right? Yeah, and somebody at another session said something about the mechanism by which cocoa butter decreases stretch marks, and I didn't quite see the evidence, the physiologic basis for it. I don't know. Maybe it does have some vitamin or something in it that decreases the scar tissue. But so let's do another question. So, which of the following options best describes a hypertrophic scar? Okay. So I understand where a group or the 50% that chose A came from. So the hypertrophic scar is actually considered a mature scar, and a mature scar is still predominantly type 1 collagen, all right? This is in the remodel. It's already gone in the remodeling phase. Hypertrophic scar as distinct from a keloid, thank you, is that excision and reclosure is potentially helpful in a hypertrophic scar versus a keloid. As you probably know, the more you cut, the more likely they're going to just get another keloid, right, potentially. Okay. So here we are, hypertrophic scar. It's similar to a keloid in that there is a more substrate deposited in an unorganized manner than is expected, but the thing about hypertrophic scars is that it stays within the bounds of the original incision. So what does it look like? It just looks like a really beefy incision. It looks like a really beefy scar, right? Okay, as opposed to a keloid, clearly doesn't follow the pattern of your initial incision. Sometimes you see patients who come in with keloids, and you have no idea where their initial incision is anymore, right? Because they just grow outside the bounds of the original incision. This too is also an overabundance, and not only an overabundance, but a disorganization of the collagen that is deposited. There is a dark skin patient predisposition, so classically African Americans, Asians, and of an unknown reason for it. Implications of tissue handling, right? So I kind of touched upon this a little bit. So, I think it's just the right thing to say, to be gentle and to be delicate with the tissue, but I don't know how hard I squeeze on the Adsons is too much for the skin. I really don't. But electrocautery causes tissue necrosis, which is a stimulus for intense inflammation, right? So you electrocauterize a tissue bed. It immediately causes coagulation of the vessels, right? So it's disruptive to the natural inflammatory process because that vasoconstriction happened without the tissue having the ability to chemotractically attract important cells. And so it kind of vasoconstricted and became necrotic, a little bit out of order. Hemostasis, if you achieve hemostasis, there's less debris for things to clear out, right? Because there's just less clot, there's less debris. Traumatic handling, again, speaks to the idea that tissues become non-viable. And then tension lines, we already talked about, is if you go against the tension line, if you're just a rebel and you really wanted to go against the skin line, what happens is that the tension places the collagen deposition at odds or not in parallel with the initial wound or initial incision. Let's talk about wounds. So we kind of talked about primary closure, all right? So you made an incision, you close it up. Here's the process of healing. What if you left a wound open, right, to close by secondary intention or by granulation tissues? The granulation tissue in open beds is that the same sequence is followed globally, but the tissue at different levels are doing it at a different pace, if that makes sense. So there's almost like a marching there's a front that is marching, and every little tissue line behind it is at a different phase, all right? It requires everything that the normal wound healing process requires, right? It goes through all the processes, but I would argue that because it's a far longer process, which is why the vast majority of us would prefer to do primary closure if we can, because it's a longer process, it's a more difficult process to be successful at, right? Just think about all the limitations previously. Nutritional factors, collagen's not lining up with their incisional lines, not lining up parallel to them. So all the risk factors that you had to poor wound healing before is now just multiplied because now you have this just long duration of it. The acute inflammation is at the advancing edge of the epithelium. So that's the most active. And that's one of the reasons for those of us who who see open wounds that we debride, right? We debride the devitalized tissue because we're trying to help the phagocytosis. We're trying to help the inflammatory and proliferative phases happen without having to work so long. You can leave the fibrinous exudate in there. It just takes forever for our body to try to chew that up, right, and to clear the debris so that we can lay the foundation upon which to rebuild. Let's see, incisions and open wounds. So the differences here are some goals. Incisions where focus is on tensile strength, right? Because we're literally talking about a collagen deposition. But open wounds is focusing on epithelialization. I don't for one minute think that patients who are granulated, who are closed by secondary intention, have any hope of achieving the 80% tensile strength of previous tissue of somebody who had a primary closure, if that makes any sense. If you are granulated, if you had tissue beds that are granulated, they're just not going to be as strong. So all we're really talking about now is let's get coverage, right? Let's just get this wound covered. And that's where that granulation tissue comes from. We'll talk about negative pressure dressings in a bit. Wound contraction. So you start with, you know how over time sometimes the wounds contract a little bit. This is not as important in what do we call it? Humans. It's far more important in animals, right? So myofibroblasts come in, right? You guys remember the actin and myosin sort of interactions where they slide across each other and all this? This is very important for muscle contraction. So the actin filaments pull the wounds closer together, okay? Why do I say that that's not as important for humans? Because, I mean, how much wound contraction do you really see after an incision? Not a whole lot. And there's some, months later, you tell your patients, oh, it'll get a little lighter as if you don't just expose yourself to the sun too much. It'll get a little lighter. It'll get a little, thinner and less healing ridge appearing, right? Okay, and the contributing mechanisms for more common chronic wounds in lower extremities is more dependent on wound contraction than, let's say, normal healing, right? So the chronic venous stasis ulcer wounds. Okay, colonization is expected. We're colonized all over the place, but back to my point about how epithelialization is associated with the bacterial load, right? But colonization is expected. And that's why when you were to take a swab and do a quantitative count of how much bacteria there is, 10 to the 5th organisms, right? 10 to the 5th exponential organisms is some sort of a magical cutoff to say, well, maybe we've crossed the threshold from colonization to true infection, all right? Okay, chronic wounds. All right. So why do chronic wounds happen? So let's have a clinical scenario. Let's have our chronic diabetic patient, right? Venous stasis ulcers. Okay. I don't deal with them in regular clinic in practice, but I see my patients that do have these chronic wounds, right? Why do they happen? It's because they don't have the substrate, they don't have the milieu to be able to get past the inflammatory phase. It's almost as if this is the part where we call patients immunocompromised, right? Their immune system cannot rise to the occasion to attract all the necessary things to come by to heal the wound, right? So for all the times that we hate the fact that when the patient is septic shock and has an uncontrollable inflammatory process, these patients do not mount an appropriate response, which is also one of the reasons why steroids impairs healing, right? Okay. Contributors, bacterial burden, repeated injury, poor nutrition. We already talked about malperfused regions. All right, question time. Diabetes is an independent risk factor for impaired wound healing because wow. Okay. All right. I don't need to say anything more. Okay, good. All right. Did everybody see, well, you all saw that, right? Okay. Diabetes. Okay, so there's a neuropathy component to it all, right? So the neuropathy component doesn't really contribute to the healing itself, but what's happening is that there's no recognition that this wound is opened up again, or it's infected, or it's getting worse, or that it's even there, right? The immunopathy, which all of you answered correctly in the last question, that's the problem with diabetes, right? That is the problem with diabetic patients. And they have decreased growth factors. They have marginalization of cell lines. Marginalization of cell lines is a bad player. Why? Because then you don't have all the necessary cells like polymorphonucleocytes, macrophages to do the inflammatory process. They have poor fibroblast migration. It's said that when the hemoglobin A1C goes up, all the cells that need to migrate get a little sluggish, right? There's decreased angiogenesis, all right? And there is no wound healing without angiogenesis, which is one of the reasons why negative pressure wound dressings are so good, right? Okay, and then vasculopathy, obviously inflow problem, right? There's an inflow problem, not going to heal. The substrates can't get there. Okay. Question for wound healing. So a 68-year-old nursing home patient scraped her leg on a table 3 months ago, and it is still not healing. How can we promote healing of the wound? Yes. Encourage protein intake. All right. So just sort of a word on wet to dry dressing changes. With the advent of negative pressure dressings in general, we are less and less exposing our patients to these frequent wet to dry dressing changes. And the classic thought has always been that we were debriding our patients, right? We let the sopping thing get to a dry, and then it gets stuck, and then you just yank it off and it takes all this debris with it. But we don't want to do that anymore because the dryness actually prevents healing. Moisture is our friend, we found out, okay? You know, when we were little kids, we scraped our knee. Don't our moms tell us to air it out, right? But the airing it out doesn't do anything, right? You don't want to air it out. You want it in a very nice, moist environment, as long as the moist environment is clean, right? Okay, so wet to dry dressing changes in general is less effective than we used to think. And if you really needed to do your debridement, maybe you shouldn't count on the wet to dry dressing. You should just do a sharp debridement at the bedside. Okay, antibiotic ointment has never been proven. People who soak bandages in antibiotics or none of that really works. Okay, all right. So protein intake is incredibly important. Management of wounds, okay? So epithelialization, I already touched upon this, happens in moist conditions, okay? Not like soppy wet, but moist, you know? The scab is a protective moisture, so the airing out business is well, don't do it, I guess. We can achieve a moist environment by applying an occlusive dressing, ointments, creams, and wet-to-wet dressings, okay? And again, not soppy wet to soppy wet dressings. Just wring it all out so it's kind of nice and moist. Keep it on there. Don't let it get completely dry, and take it away later if you really need to cover it, all right? The goal is to maintain a moist environment. Okay, question. Potential risks of poor wound healing include all of the following except. Fantastic. It's 10 to the 5th, all right? 10 to the 5th. Poor wound healing in steroid-dependent patients may be mitigated by great, vitamin A. Okay. Zinc is essential for all except great, yeah. So zinc is a very important spice in life, and it's involved in everything that's rapidly dividing and changing, right? So DNA synthesis, cell division, and protein synthesis are all very dependent on zinc factors. And for that matter, I think it's important just to be cognizant for testing purposes anyways, all these factors that are so important, cofactors that are important, in all of general surgery. Prime examples like magnesium, right? One can't correct calcium without correcting magnesium, right? Those concepts are very testable concepts, which you probably don't come up with. We don't probably encounter too much in real life and real clinical practices, all right? So factors affecting wound healing, we already talked about a lot of this stuff. Radiation is something that we didn't talk about, right? Radiation destroys anything that's fast, that's rapidly dividing, that's rapidly changing, including fibroblasts. So that's why patients who have previously irradiated have impaired fibroblast migration and fibroblast action. Smoking decreases the oxygen tension to the bed. It decreases angiogenesis and thereby neovascularization of a healing bed. Diabetes, we talked about already. Edema. So edema is interesting, right? The chronic venous stasis patients or anybody with chronic venous chronic edema, their wounds are difficult to heal, and that's because there's decreased the transport, their ability to transport the substrate. There's an outflow obstruction from the venous congestion, if we can sort of see it in a very cartoonish fashion, and so therefore the substrate can't come in. There's no cycling of this. There's no clearing of the old and coming in with the new, right? So that's why edema is not good for your healing either. Oh, and by the way, when we overly aggressively resuscitate somebody and cause them significant amount of edema in their tissue beds, that wound's you're gonna get an incisional hernia. Why? Because never mind the fact that when the edema goes away, all your sutures are loose, right? But it's also because of this. There's a decrease in transport substrate and venous congestion. Yes, sir. The question is what I'm talking about in terms of the processes for wound healing. Does it apply to both soft tissue and fascia? They're generally the same. They're generally the same. I will say a couple of caveats. Fat is very, very poorly vascularized. So you all know that, right? Fat liquefies. So fat is very, very poorly vascularized. So fat doesn't participate in this process very much. So then you're down to really what you're talking about: skin, muscle, and fascia. Right? All the skin and the fascia will both go through the global scenario of the multiple phases. When we talk about tensile strength, we're talking about the fascia mostly. I mean, there is skin tensile strength, but the real tensile strength that we care about is the fascia. So, and fascia, I know it looks different than your skin, but it also is still predominantly type 1 collagen. There is some thought that maybe the cross-linking or the stabilization of the collagen is stronger in fascia, which is why it gives you the absolute higher tensile strength as compared to your skin, I guess. Right? But the same process. Oh, whoops. Pressure ulcers. Pressure ulcers is less about the pressure, more about the reperfusion when the pressure is let go. So I suppose one can make the argument if you just let the person stay there forever that they wouldn't get the reperfusion injury. But it's because they've been on this area that has not been perfused for very well, and it's actually when you take them off the pressure that they get the reperfusion injury. The turning helps by not having this prolonged period of ischemia. All right, right. Everybody knows that decubitus ulcers is a hospital measure, right? So the skin is more resilient to pressure than the muscle or fat, and that's why you can potentially understage the decubitus ulcer, because the skin looks like, oh, there's a little bit of redness, I don't know, but then underneath it, the muscle and the bone are actually not nearly as resilient to the periods of ischemia, right? So how do we mitigate? What are risk factors that we can potentially mitigate? Well, immobility, right? Particularly our obese patients, when they're in the ICU, they're on the ventilator, we turn, right? Some patients have those beds that have those pressure waves that come through, or get them out of bed so they don't have immobility. Obesity clearly is a risk factor for this. Not anything that we can help right away in a short term. Poor nutrition is yet another risk factor that can be mitigated, that we can contribute to. And then infection, right? So the infection part goes back to the chronic wounds that don't heal. Right. Negative pressure wound therapy, right? So whoever, I don't know who came up with this really, I probably can find out, but whoever came up with negative pressure wound should get a Nobel Prize, right? Because it's revolutionized medicine. They should get a Nobel Prize in medicine. It's truly revolutionized the way we care for wounds. We have lots and lots of wounds, right? So much so that, trainees these days just jump right to a wound. They don't think wet to dry or wet to wet or wet to whatever that we do. They go, let's do a vac. right? But then the downside is then you got to wear a little pouch and everything at home. So there are other factors in it. But the beautiful thing about the negative pressure dressing, much like, I'm going to get off topic for 1 second, much like milrinone, which is a phosphodiesterase inhibitor in the critical care section, I think of it as a miracle thing. It's because phosphodiesterase, right, increases your contractility and decreases your afterload. So your heart is pumping better against less resistance. That's a miracle drug, right? Negative pressure dressing is doing everything that we need it to do to help wounds heal. And what is that? Keep a moist environment, right? Entice growth factors, entice neovascularization. Putting that pressure on that increases the fibroblasts and all those growth factors. So it's not just a cover it up and it's sucking the wound edges together. It's actually inducing the normal wound healing process at an accelerated rate. Primary intention, secondary intention, delayed primary closure. I just want to mention that for delayed primary closure, the nice thing about it, and that's why we should all attempt to do it anyways, is that all the substrate for the inflammatory process is already there when you made your initial injury, right? So delayed primary closure, or for that matter, reopening of your XLAB, reopening of your wound and then closing it again the second time, that process no longer starts from the beginning. The inflammatory phase is already there. So it's a little bit more rapid in terms of its progression, all right? This slide, I should put a little bit earlier regarding the hydroxylation, vitamin C dependent hydroxylation. First of all, you see that you see the tensile strength. Once again, that asymptotic life graph doesn't quite ever reach baseline, right? Okay, but you'll see that the importance of hydroxylation of the collagen in this entire process leads to your proliferation and your tensile strength. Wound tensile strength is increased by great. Anything that promotes collagen synthesis and stabilization. So clearly if vitamin C, it wasn't deficiency, but in fact vitamin C, that would be very helpful, right? So things that help with collagen synthesis, and that's why for the sake of having enough substrate, nutrition is so important, right? Nutrition is incredibly important. All right, we already talked about this a little bit, epithelialization. So a quick thing on skin grafting, all right? So skin grafts, is not microvascular surgery. We don't make anastomoses. We take a piece of skin from somebody else or from you, and we put it into the wound, and we say, all right, let the neovascularization, let the local processes feed this graft until neovascularization takes place. It's a miracle to me that it works at all, and I guess, frankly, I don't have a great skin graft take. I publicly not acknowledge, and the reason for that is probably technical in nature. But when you think about what has to happen for a skin graft to take, right? Once again, what has revolutionized skin graft taking? Negative pressure dressings, right? Put it there and leave it alone, right? Apparently, that's the rule. Is you're not supposed to look at it for 3 days because our temptation is we go messing with it and we slide it around on this milieu, and all those tiny little vessels are torn and it doesn't take, right? So the donor receives nutrients for capillary action absorption. It's called inhibition, right? And this happens in the first 24, 48 hours. So important not to go touching it. Just leave it alone, right? That's why negative pressure is so great. And then what happens is a process called inosculation when the thing is actually forming little connections like neovascular connections to the tissue bed. And after all that's done, it actually reinnervates. It's amazing, I think. What happens with the skin graft. I think of it as sort of akin to us using biologics, where that biologic sort of just takes on, it's just a lattice work and it just takes on the local properties of whatever tissue bed you put it in, which is why, of course, you know that biologics don't incorporate very well when you put it in an intraperitoneal position because the other side of it is in contact with nothing, right? All right, so split thickness grafts is a better take. It's prone to contractures. It's poorer, I should say, cosmetic outcomes, but it's better for much larger wounds, right? You can't take a full thickness out of a large wound. Okay, full thickness and distinction then is less contracture, so cosmetically more pleasing. So what do we use full thickness for cosmetically important areas, right? Like the face and the ear and things like this. But it's only really good for small amounts of coverage. The problem with full thickness is that the imbibition process is dubious because it's so thick, I guess, right? So so there's that. All right. Recipient preparation. We want to maintain that the recipient is also that the patient has as clean as possible as skin as possible, right? We want to maximize their nutrition, and we want to just do a little swab, make sure that the area that you're taking doesn't have a greater than 10 to the 5th bacterial count because it's associated with graft failure. Okay. All right. So these negative pressure people should hire me to be their spokesperson, because here I am talking about how great negative pressure dressings are again, because it decreases bacterial load. Well, how does it do that? Well, it's very physical. It just literally sucks it all out, doesn't it? Like, it doesn't allow that to sit there and to proliferate. It maintains a moist environment. So one of my residents asked, and I thought it was a simple but very difficult question to answer. They goes, I understand you're sucking constantly. If you're constantly sucking things out, how are you maintaining a moist environment? And I guess it's just moist enough. I don't know, maybe somebody in the audience knows the answer to that. But it does maintain a moist environment. I think it's because it is occlusive. Significantly fewer graft losses with negative pressure dressing, all right? Shorter hospital stay. It's just good stuff, all right? Take a dermatome. And we use lidocaine with Episoak gauze to the donor site, because you know all those little areas that are punctate bleeding. You can stretch it out actually quite a bit, but you don't want to overstretch it because then you start getting the pie holing, right? So this is how you stretch it out. There's a dermatome thing on the left side of your screen, right? And look at that coverage, right? This has clearly been stretched out, okay? But this is what happens when your skin graft doesn't work, right? Because look at it, it's just completely necrotic. And you notice, and some people actually stitch the skin graft around the corners, right? Okay, so graft failure, movement of the graft, hematoma, seromas, poor recipient site, overstretching the graft. We kind of already touched base on all this stuff. I think that's it. Any questions about wound healing?